Good evening, everybody. My name is Adam Ramol. I'm the Professional Education Manager for Lena Medical USA. Tonight, we're doing a webinar on the EnPlace ligament fixation device from FEMSelect. I have the pleasure of having Dr. Andrea Pizzella here from Columbia, South Carolina, capital city, and she's going to do the presentation tonight. So I would just want to thank everybody for being on here. One quick thing, note on the right-hand side of your screen, there is a questions section as well as a chat section. We'll be monitoring that throughout the presentation. So please, any questions that come up, rather than interrupting Dr. Pizzella during a particular slide, just go ahead and send us your question. Or if you want to, make a note of it. And at the end, if we need to, we can open up people's microphones if you want to, so either the chat function or the questions. So let me quickly tell you a little bit about Dr. Pizzella. If you go to the next slide. All right, so Dr. Pizzella is the founder and director of Southern Urogynecology Center for Female Pelvic Medicine and Reconstructive Surgery, as well as the director of the Division of Wellness and Aesthetics in Columbia, South Carolina. Dr. Pizzella has dedicated her practice in pelvic floor reconstruction, advanced therapies for urinary incontinence, and cosmetic gynecology. She's board certified in urogynecology and fellowship trained in cosmetic gynecology. Dr. Pizzella also holds an academic appointment as clinical professor in the Department of OBGYN at the University of South Carolina School of Medicine. So now, without further ado, I'll turn it over to Dr. Pizzella.
Thank you, Adam. I really appreciate the introduction, and thank you everyone this evening for coming and listening to this webinar on EnPlace. I have the pleasure of being part of EnPlace for a few years now, and being able to use the product. I have had pretty much, it's been a game changer in my practice. Before we get started, if some housekeeping, FEMSelect follows the AVAMED guidance and Sunshine Act, so I have to report that I am a proctor for EnPlace, a speaker for FEMSelect, and I have no other disclosures. This is, I'm not going to, busy slide, I'm not going to, because we're going to be talking about EnPlace throughout the entire lecture this evening. There is a small QR code in the corner of the slide regarding the product description and the instructions for use, so you can actually use that QR code, and I will also place that on the screen at the end of the lecture. Again, EnPlace is a device, it is not a procedure, and we're going to go over how the device has been implemented in an innovative transcutaneous procedure for pelvic organ prolapse. EnPlace, again, is not a procedure, and of course this is a lecture on the device itself and the innovation of using it in your pelvic prolapse repairs. So one of the reasons I use EnPlace is what I've seen, and actually when I got my hands on it, how it really just translated to me an improvement in my apical repairs. So I was introduced to EnPlace by a mentor. I had the support and proctoring and instruction on how to place the device, and so that was really important because, again, it's a different, innovative way to do apical suspension. And so, and it was interesting to me because in this right now where the pendulum swings back and forth with whether we're doing robotics, sacrocolpopexy, or transvaginal repairs, there really at this point was a need for a transvaginal approach for apical repair. Since the transvaginal mesh was abolished, it really, and using biologics, there really was a need for something else. And so it was interesting that this came up. Dr. Lucente actually mentioned it to me, and he started talking to me about it, and it was really a game changer for me when I got my hands on it. because I was accustomed to doing a hysterectomy or uterosacral suspension. So I found that EnPlace for me, I could integrate this in my practice very easily. So what is EnPlace? EnPlace is a transvaginal percutaneous approach to fixating your sacrospinous ligaments bilaterally. So it has two of these main elements. It has a anchor suture unit and then a guided finger guide, I call it, delivery system. And so the system uses the finger guide as your working channel for the insertion and deployment of that suture anchor unit. So there are two of those suture anchor units in a kit, and there are two finger guides, one for right and left. And so you have the device set up. The polypropylene suture, which is pre-attached to the anchor, the nitinol anchor, is already inside the trocar, if you will. And so you are able to bilaterally anchor the sacrospinous ligament with the completion of this device. So its features, it is a minimally invasive way, so it has an anchor so that you can actually go through and penetrate through the full thickness of the vaginal mucosa and go straight into the sacrospinous ligament. With the use of the finger guide, you are able to deploy along the trocar the anchor into place. So there's accuracy because you're using the direct palpation of your finger where your finger guide is fitted through, and so that finger guide system allows you, and then you have that, I wish I had a pointer, you have the actual elements of the working channels that you can insert that trocar through. So you have the ability to actually compress with your finger guide down onto the vaginal mucosa at the sacrospinous ligament, and the location is the middle thirds. So you get to the sacrospinous ligament and you march out and you can palpate your sacrospinous, your sacrospine, and then to go medially to the edge of your sacrum to find your middle third. So you're going into the depth of, and you could feel the sacrospinous ligament at that location. This is very safe. I think there's patient benefits to this. There's minimal pain with the anchor fixation, and the operative time is considerably less. And for me, it's been a game changer because you don't have to do that full transvaginal, paravaginal dissection that is required in our transvaginal mesh repairs and the biologic mesh repairs that we've kind of become accustomed to. So how does EnPlace differ? Like I said, from the transitional repair, we're doing these large paravaginal dissections where we're dissecting out to the sacrospinous ligament on either side. So you're going to have minimal blood loss because you're reducing, you're placing an anchor through and puncturing through the vaginal mucosa, and then you're making a small linear incision on the lip of the cervix. So you're reducing significant dissection, blood loss, tissue scarring, and your surgical time. So this, for me, has reduced my surgical time to do a uterine suspension. I think that also too, these patients, I'm able to do them under sedation, heavy sedation versus general anesthesia, which is required with a hysterectomy. And my patients are going home. So I'm setting these patients up so that they can go home the same day. Because there is very little dissection, so very little pain, and with the decrease in the OR time and the decrease of anesthesia exposure, these patients are, I was telling my rep earlier, I'm no sooner done with my second EnPlace, my first EnPlace procedure, I'm walking down the hallway and they're rolling her out to the discharge door. So that has been, for me, one of the more remarkable things that I've noticed with my change in my practice. So with everything, there's evolution, and I think that for all reasons improves outcomes. And I think FEMSelect as a team and a company has really taken our physician feedback, and since the beginning of the EnPlace into what we're using now, there's been some changes, and I think that has really been helpful. And I think as a team, I think they're really interested in the physicians' feedback and what we can bring to them to make it a better product. So the placement of the suture was a with the little inserter stopper was extended so that there was 5 millimeters extended to improve the axis of the ligament. We found that there is a thickness of that vaginal mucosa that anchor must puncture through to get to the sacrospinous ligament in order to have a secure anchor into the ligament. And then as we went along, that placement of the anchor is key. So what we really want to see is we want to see accuracy, reproducibility, and we want to be able to have very similar outcomes from one physician to the other, because we have everybody's trained differently and everybody has their own nuances on how they approach their pelvic floor reconstruction. But the placing of the anchor and the medial aspect, what we talked about is the middle third, and that lower half of the sacrospinous ligament does a couple things. One, again, gives everybody a guidance of where exactly we want that anchor to be placed. And so you're getting reproducibility, but you're also looking for safety. And so you're in a safe place. So we're eliminating the risks of injury to a blood vessel or getting next to any nerves, the pudendal nerve being one. So this is where I think that's really important. And then a 4-point fixation. So when your sutures are going through the cervix, we're passing them individually on either side. So you get that 4-point fixation. I think that gives us a little bit more security, and you're really using that cervical stroma to create that durability of the fixation. So that is kind of where the evolution has gone, which I think is great. Another thing, so a lot of physicians will ask me, and they appreciate, you're not solely dealing with the cervix that is prolapse. You obviously, in a lot of times, have a anterior compartment prolapse where you have to address. And so this is compliments of Dr. Lucente. There's that transverse anterior kyporphy, and I've adopted this very quickly when I also noted that this is not just a solitary cervical prolapse. You have a anterior defect and you have some distension. And so what you can see is that we're in the first picture at the VA, is quite long, and we really want to take account for that. So that is done once the anchors are placed, and once your cervical dissection is performed, and those Prolene sutures are then tunneled underneath and go through the cervical stroma on either side, then you can address the anterior vaginal wall. And this compartment distension, as you can see, can be taken care of because it's longitudinal. So you can actually very well see here that there's a big distension in the length. And so there's that transverse defect. So here you can see there's alluses that are grasped on that vaginal mucosa that has been dissected off of the cervix, and you're dissecting the pubovesical cervical fascia off of the, you see cephalid, off of the vaginal mucosa. So this just kind of correlates very much so with the works of Delancey with his dynamic MRI work, where the distension is happens lengthwise. So that's when the vaginal wall gets longer. So this is trying to take care of that anterior compartment at the same time. Those sutures are, once the vaginal mucosa is trimmed away, the pubovesical cervical fascia anteriorly and then below the sutures that are in the cervical stroma, we take like a 2.0 PDS and grab on either side, and then I actually that gets closed actually after the anchor sutures are suspended. So I think we all like to have clinical outcomes and we all like to look at data, and I think that's very important when I discuss this procedure with my patients. I'm very transparent that there is limited data, but we're getting more and more, and we do have 4-year prospective follow-up data that's focused on safety and efficacy. And again, that's what I tell my patients. We're looking at this, and I have used this longer. It's been in my hands longer, but we want to show them and that there has been long-term data, and we're continuing to see that. 12-month post-market clinical studies focusing on safety and durability, also showing very safe procedure with high efficacy rates, with low morbidity, and I think also too something that was very interesting for me when I just recently presented to the VAC committee, lowering the cost, and they look at the cost of the actual device itself, but then I had to demonstrate to them the lower the cost of the anesthesia time and the OR time, since it's a shorter procedure. There also will be to come 24-month data as well. So how did I incorporate this into my practice? So it's really starting the conversation. Once I was introduced to the EnPlace and I had my training, during that time it took to set up, to get proctoring, I looked at each patient, and I had an opportunity to talk to my patients and see if they were interested in surgical procedure, were they wearing a pessary. So I kind of looked at two schools of patients. I looked at patients that were not interested in surgery at all, and I looked at patients that were actually just regular patients coming in and out of my office that were using a pessary. And they just figured at this point it was the only option for them. And I was pleasantly surprised how many women were actually interested in a surgical procedure when I discussed with them the fact that this was minimally invasive, they wouldn't have to stay in the hospital, there was really minimal downtime. I told them that their return to normal activity was pretty quick, within a few days, and they really didn't have any restrictions. And so that was very appealing to them. So I looked at this and very quickly was able to make it appealing to my patient population. I felt that the patients that were not interested in surgery were easily convinced after talking to them. And that's, I think, one of the big things, and what I emphasize is that your confidence. When I adopt a procedure, I want to be, and this is my OCD, but I want to perfect it, and I want to be able to reproduce it, and I want to see its outcomes in my hands. And then I can actually deliver that information to my patients. And so the data that we show you and the data that we read, it's really what comes down to when it's in my hands. And so the patient, I think it resonates with the patient when I do that. I think the patients that are not interested in a pessary solution, I think that was another patient population that I was really able to introduce this to, and it became very appealing, and they were excited when they knew that there was another option. So what I did was, I started to allude to it. I created a treatment algorithm, and that treatment algorithm allowed me to kind of set up in my head, okay, who am I going to introduce this to? And then as I started to do more, then I broadened. So what I first did is I looked at, you know, age, I looked at their anatomy. I thought that maybe just a single solitary cervical prolapse was sort of for my learning curve anyway, to be able to start with those patients. Certainly patients who had previous surgical history, and then getting more information if they'd had more abdominal surgery. I would tend to want to go more vaginal approach. And then certainly those patients that desired a more minimally less invasive, because there are women out there now that are really seeking minimally invasive options, and they are asking, do I have to have a hysterectomy? Which leads to a whole other conversation. I think they also want to get back to their regular physical activity quickly, so that minimally invasive approach is very appealing. So that's kind of how I set up my treatment algorithm, and because I do a high volume of robotic hysterectomy concomitant with sacrocolpopexy, I had to decide which patients were going to be my EnPlace candidates and which patients would I continue with sacrocolpopexy. And it became very interesting that I started to offer both and create a shared decision-making process for those patients. And it really was interesting how many patients were more interested in EnPlace. And I was very fair with them. I said, listen, I've only been, you know, at that point, you know, say using EnPlace for now 2 years, where I've been doing robotic sacrocolpopexy for, you know, over 10. And so they were still interested because they desired that meshless procedure and desired a uterine sparing procedure and a lot less invasive. So again, my learning curve, you know, mine, I would say, you know, it was about 5 completed cases where I felt like I was competent in placement. There are nuances with every anatomy, with every patient, as we all know. So you can't just say, okay, I'll do 5 and I'm you know, completely confident in the procedure. I always say, like, sometimes I walk in the OR on Monday morning and I feel like I'm doing the procedure for the first time. So you definitely want to be able to have different patient populations, the single solitary uterine prolapse, and then have one with you know, an anterior compartment distension, and then of course uterine prolapse with cystocele, rectocele. So then you're just able to do a variety of different ways to approach it, especially if a patient has a narrow introitus versus a patient is more redundant. I think those can also create some different struggles when approaching with the EnPlace. So there was definitely an unmet need in terms of our aging population, the incidence of pelvic organ prolapse, and the patients wanting more options. And so again, with mesh kits taken off the market, for me personally, I felt like my transvaginal repairs, I was certainly open to a biologic where I was doing that paravaginal vaginal dissection, and I was placing my sacrospinous fixation anchors with suture, and then creating a biologic. Then I went back to vaginal hysterectomy, which I was very well trained, and that was certainly something that is becoming less and less common now in our training. And I was doing vaginal hysterectomy with uterosacral suspension. So this, to me, all of a sudden there was an aha moment for me where I was like, this could work out great for the urogynecologist like myself, who was trained to, you know, to do a hysterectomy or to do a transvaginal paravaginal repair or transvaginal mesh repair, which we still with the mesh kits miss and loved. But what other physician would would this unmet need take place? And I think the urologist often maybe not trained, the general urologist not trained to do a hysterectomy, who is interested in doing pelvic repairs and cystocele repairs, but then they see a patient and they have a cystocele, and then lo and behold, they also have a uterine prolapse. So then they sort of either call their gynecologist, or they convince the patient that they don't need the surgery, or for whatever reason they kind of they hesitate, or they have them see the gynecologist and then they come back and see them, and then they have to educate the patient that they have to do this procedure together, which then of course trying to collaborate two surgeons in the OR nowadays is so difficult, so causes conflict with the patient. So EnPlace could be easily incorporated in their practice, where they would do the cystocele repair with the EnPlace, and they can easily train on the EnPlace procedure with all of its new innovation and changes with the product. I think it can be very much appealing and be a more comprehensive surgery for them without having to send them to the gynecologist. Now, as far as a urogynecologist, they often don't learn, and hysteropexy was sort of a new word to me. So that puts a whole different perspective as far as a urogynecologist and where they trained and what they were accustomed to doing. And they didn't really learn a good hysteropexy. So this really, for the urogynecologist, even gynecologists, where hysteropexy really wasn't very commonly performed, it brings it to a whole other level, where that patient who desires uterine sparing, we can give them an option. So yeah, why hysteropexy? Well, I mean, hysterectomy is the second most common surgery outside of a DNC in women, and so we are doing hysterectomies all the time in our gynecologic trained urogynes, and so it really is something that I think is the conversation with the patient, to give them alternatives and give them options. So hysterectomies are performed for benign procedures most commonly, and only 10% are really performed for cancer. So we see, you know, in ACOG, the vaginal hysterectomy is the least risk, but there's a lot of risks with hysterectomy, and a lot of them are not necessary. So we're taking a risk, and we're putting our patients at risk by doing a hysterectomy. I think hysterectomy rates are decreasing with all the other alternatives that we have, with uterine artery embolization and ablation techniques, and now with hysteropexy. I think there is that need for a minimally invasive treatment, which is now increasing with these women that are wanting to get back to routine activity at a quicker time. So this was a systematic review, and was hysteropexy versus other procedures, like I mentioned. And at the end of the day, there was a lower adverse events in all aspects. And so hysteropexy versus hysterectomy for prolapse repair was without a doubt safer in terms of lowering urinary tract infections, surgical site infections, and all the very, noted hysterectomy risks: ureteral artery injury, ureteral injury, and your postoperative retention rates. So for just in itself, hysteropexy seems to be the lead as far as reducing our outcomes. Because at the end of the day, safety, safety, safety. You want to offer your patient something that is safe and effective, and in all aspects, I think safety is number one. And when you are challenged in the hospital by using or requesting to use a device, you bring up safety, and you bring up less cost, and I think it's going to be a win-win for you. Again, with hysterectomy plus mesh sacral colpopexy versus uterine preservation with sacral hysteropexy. This was a cohort, a comparative consideration that at the end of the day, where you're looking at the hysteropexy group, the uterine preserving surgery improved your operative time, your blood loss, and any risk of mesh exposure. And it didn't change your outcomes at all with your prolapse repair, at least short term. So, so this is really what resonates, I think, to the people that I'm talking to tonight, are physicians that, really want to know, what the outcomes are, and, and what are the benefits, and looking at the data. Well, that went quick. I think we have a lot of time for our questions and answers, and I will let Adam, I'll pass the baton to him and let him take over, and we can have
Okay.
nice little dialogue. See that we have a lot of
Yeah.
attendees.
Can you hear me okay, Dr. Pizzella?
Yes, I can.
Okay, great. Fantastic job. That was a ton of information, really, really great from start to finish, really good coverage of all the information about the procedure. We did have one question, and I'll just remind everybody while we're answering a couple of questions here. Any other questions that you have, please go ahead and send them in. But one of the questions was about the concomitant procedures. So you mentioned the anterior repair. So the EnPlace is primarily for vault prolapse, correct? And then what other procedures are you doing in conjunction with the EnPlace procedure?
Right, so your EnPlace procedure is only going to offer your apical support. So that's for your hysteropexy. If you have, and what the picture showed, before you tie and suspend your, do your apical suspension and tie and close your cervical suspension, you're going to do that transverse repair with the transverse anterior coporphy. And so I do that concomitantly when I have, even if I have a small distension. I think it is nice because that length of the vagina, and it was demonstrated by those pictures, that's the distension of that anterior compartment. And so you're able to do that at the same time before your closure of your cervical opening. So you're going to make your opening of the cervix, and you're going to do your transvaginal placement of your anchors. You're going to then percutaneously and underneath the vaginal mucosa, bring those anchors deliver those with a needle driver with the needle through the cervical stroma, and then once those are intact, that's when you'll address your anterior compartment defect. If there's a posterior, I'll do all that, close, and then if you still have, if you have a rectocele, then you'll do your conventional rectocele the same way that you normally perform a rectocele.
Okay.
Does that answer the question?
Yeah, definitely. We also had a question about the use of nickel for the anchor. This question actually came up in the last webinar, and as opposed to, I think it was more of a manufacturing question as to why the manufacturer chose to use nickel. Partly has to do with the way the anchor is made, the way that the wings are able to open up, and the way the device is designed. So I'll leave that question more to this person's sales rep to get him a better answer, unless you have anything to elaborate on the use of the nickel anchor.
And I had this conversation with Dr. Lucente, and I believe we were on a call. I had a patient that she thought she was allergic to nickel. She would get black around jewelry like earrings, and I used it in her, and I did not have any problems. So you got to really address what the allergy is, and what what kind of allergic reaction they have. But I think as far as I'm concerned, I think that nickel is a very safe metal to use.
Okay. Another question just came in. How does use of EnPlace compare to sacrospinous ligament fixation hysteropexy in regards to postoperative gluteal pain?
So yeah, so I'm finding that with an anchor, you're not going around the ligament or muscle, and so you're not strangulating the tissue at all. So I think that I'm seeing hardly any gluteal pain because you're not tying, if you will. Once you take a suture and you tie down, you're creating constriction of that portion of that tissue, of that ligament. So that's, I think, what causes that gluteal pain.
Okay, good. And actually, this wasn't part of the question, but this often comes up when we're out in the field. Any other intraoperative or postoperative complications that you run into? You know, we always have physicians who are concerned about rectal injuries. You mentioned the finger guide, and I know part of the function of the finger guide is also to keep the rectum out of the way. But any other complications that you run into? Anything that they need to look out for out there?
So, knock on wood, fortunately, I have not. You can get close to the rectum. I think that there's in the inferior gluteal, there's some blood vessels that you can get. I think if you're not, and particularly if you're training with residents or fellows, you know, you want to, do a lion's share of these yourself before you start, because it's their palpation. You can't, at the end of the day, know where they're actually placing the anchor. So you just sweep the finger guide directly onto the sacrospinous ligament, and you also have to be careful too, because you can slide or kind of bump up, if you will, and then you can actually skive the ligament and not get all the way through. I've had one that actually didn't go all the way through, and I pulled it out and I was able to reload it. And I think that's something that we all have probably shared. You can reload the anchor back into the trocar. So I always do a rectal examination. Once I placed my anchors, I do a rectal. I do cystoscopy. That's routine. I feel that it takes me a few minutes to do a cystoscope, so I am confident so that I can kind of sleep at night, knowing that I've checked rectally and cystoscopically for any injury to other organs.
And when you do the rectal exam, what do you actually feel? Can
So
you actually feel
the
where
rectal exam, I actually pull onto the anchor, and I actually sweep laterally, and you can feel behind the rectal mucosa. You can somewhat feel the proline. You can feel the proline.
Okay. Yeah, because we've had physicians who, when they've done their first case, when they do the rectal exam, they're like, oh yeah, I can actually, and so just so they know.
Yeah, as long as you don't feel it and you can bring your finger through and you can pull the proline out through the rectum. Yeah.
Understood. Again, we won't talk about that anymore.
No.
So one of the other questions came, are patients going home on narcotics, or so what's your post-op regimen for the patient?
Yeah, so we I do offer a few. I think that if you it's really educating the patient too. Most of my patients, I'll give them some Tylenol, naproxen, and it's our ERAS, and the gabapentin prior to surgery. Then they get propofol. I will do, it's a 0.5% Marcaine with epi at the cervix for my dissection of the cervix. And then pretty much afterwards, they'll go home with extra strength Tylenol or ibuprofen. I would give them a Toradol, IV Toradol post-operatively. because there's no bleeding. I mean, there's hardly any bleeding, so I don't have any problem giving them Toradol. There are a few patients I'll give them a handful. I'll give them like 5 hydrocodone, just in case. You don't want to get that call in the middle of the night, especially if you're doing a concomitant rectocele repair, where that's obviously going to be a little bit more uncomfortable than just the EnPlace. For just an EnPlace with anterior porphyry or EnPlace alone, they're taking extra strength Tylenol.
Gotcha. And to switch gears a little bit, on the patient selection portion of it, I thought it was really interesting, your algorithm that you use and what type of patients that you're choosing to do this on. I think, you know, it's a big question with the robotic sacrocolpopexy, and you really addressed that really well as to how that, maybe a little further question. I have family in South Carolina, and I was speaking to a doctor recently from Georgia, and I was very surprised to hear and I've been a rep in the South for 20 something years, and I was surprised to hear that well, it's time for my hysterectomy in the South kind of line has gone away. Have you found that there's less pushback from patients on retaining their uterus?
And that was interesting, and that's where it was really very timely, because I was having that conversation with patients, and I do a hysterectomy with sacrocolpopexy with robotically, and the patient would ask me time and time again, well, do I have to have a hysterectomy? And I was like, well, that's the best way to do it, and this is the gold standard. And I'd have my conversation on how, you know, simple it is, and, you know, it adds another 15, 20 minutes to my procedure. And I, you know, it's like I was, you know, convincing myself when I'm trying to, you know, convincing the patient. I think that really lends to that ability for me to now have that conversation with the confidence that I have with EnPlace, that I've switched a lot of patients that I would have normally. Of course, I have to do my 20 robotic cases a year in order to keep my privileges, but I've definitely changed and probably switched a lot of my what I've normally done robotically to the EnPlace. But yeah, and my algorithm, since I've made those slides, is, you know, I'm like, you know, EnPlace for everyone. I think feel like, and that wasn't, you know, a commercialized. I just feel like I enjoy. I was a transvaginal trained surgeon, and I've always enjoyed that route. And you know, whenever you're going under general anesthesia and in the abdomen, I mean, there's a whole host of comorbidities that can happen. So for me, I just was elated to be able to have something in my hands that I could. Then I really switched my paradigm in my practice. So it's been great.
And then also related to that, does BMI factor into the decision for the route?
Absolutely. I mean, I have patients that, you know, I'm from the South. I'm not from the South, but I might as well be. I've been here 16 years, and although I can't say y'all, my patients are on the heavier side. So I definitely, you know, have done my fair share of obese women, and I've just, you know, it becomes a challenge and continue to become a challenge. So this definitely, you know, over BMI, certainly I choose EnPlace, and the multiple abdominal surgeries that they've had. So that definitely helped me with my decision making, for sure.
Yeah, for sure. And then I think the only is there anything you can elaborate on your VAC discussions? You're getting approval into the hospital. I know you've had a couple of additional hospitals these days come on board through you. One of the things we get a lot of, you know, we get a lot of pushback from VAC, of course, all the time, because it's always pushback. But it sounds like from what you were talking about, you're bringing more surgical patients into the hospital. Is that something that's advantageous, or is there
Right.
good around that?
So what you have to demonstrate, and because I had to go to the VAC committee twice with this, and so my first time, it wasn't really what I didn't speak of, but it was more so my audience, and so and then my level of competence. My second time, I really had to, first of all, tell them I was doing it at another hospital, so that I was taking all my patients to the different hospital systems, so that kind of perked their ears up. And then really changing the conversation of, well, how much does this widget cost? And this widget costs this much, so therefore we're not going to use that widget. And I told them, I said, but you got to look at the big picture. And if you do a cost analysis, my one device is going to be overall, the cost of that is going to be overall less, because I'm going to shave off 30 to 45 minutes of my OR time, and the patient's going to go home that day. And so the anesthesia time, the OR time, and the fact that I can do more cases in that day, in that time frame as well. So you got to really change the conversation and not make them think it's just that one, how much does this device cost, and that's how much the procedure is going to cost, because it's the whole picture, the whole cost analysis. So, and the safety feature, I mean, when we're talking less operative time, you're talking about less dissection, less blood loss, less morbidity to the patient, and then I can bring my surgeries to your hospital. I think that's when they change their tune.
That's perfect. Yeah, that's great. That's fantastic. I think that's it for the questions. Give a last call if anybody wants to fire in any other questions. If not, just want to thank everybody for their time and sitting here and attending this webinar. Thank you so much, Dr. Bozzella. Can't thank you enough for taking your time and doing such a great job in detailing this procedure for us and this device, and answering all these questions. And unless there's any other comments, or I think that's it for the question.
And if there's any other questions that may be offline, I'm happy to, email the participants from this evening, or if they can have my cell phone. I don't mind at all.
Oh, that's fantastic. I appreciate that. And yes, just so everybody knows, this is a really great introduction to the product. It's a lot of good information. FEMSelect, as well as Lena Medical, take the training for this device very seriously. So anybody who's attending this webinar, we can sign you up for online education through some training modules online. And then we can also set up case observations with Dr. Bozzella or some of our other proctors, and also we do labs. So contact your local sales rep, or you can contact me, Adam, at lenamed.com, and we will keep in touch with you. So I think that's it.
Thank you. Thank you so much, Adam. Thank you, everyone, for taking the time out this evening. I know everyone has such a busy schedule. Really appreciate it.
Thank you. Take care. I got